So we are recording the PNR 204 Exam 2 review. So as I said, this is all about weeks 4 and 5, chapters 21, 23, and 24. So remember, all exams are going to have questions that are exactly what you see as the definitions. So it's something that you should learn and know. There may be one, two, or all of them. You don't know what's going to be on the exam. So let me explain what they are so you know what it is. So conscious sedation is when, for instance, you break your arm, read you're on the ulnar, it's pretty bad. You have to manipulate it really hard to put a cast on. And this is in the emergency room. What they do is they give you a mixture of IV drugs where you're unconscious, but you don't need to be intubated like into the OR. Okay, you're still awake and breathing for yourself, but you're not. Don't remember a thing all about it, okay? And that's the thing about conscious sedation. It just means that child now can go home instead of waiting to wake up from recovery and go through all that process, okay? Clinical pathway. This is the interdisciplinary plan of care that displays the progress of the entire treatment plan for the client. For instance, if you came in RSV, there are orders written to tell you exactly what's going to be done day per day, shift per shift. That's called a clinical pathway. It's already predetermined. We know what's going to be going on. An emancipated minor is an adolescent who does not live with mom and dad and has gone to the court, and they can legally sign for their own medical treatment. And we need those papers to prove it. Also, their children also. They can sign for their own children and themselves. They don't need a parent as a consent. Regression is what we do in separation anxiety, right? It's the loss of an achieved level of functioning to a past level of behavior that was successful during early stages of development. So we know separation anxiety, first you're crying, and then you go into that state of despair or regression. Start sucking your thumb again. You urinate in the bed again. These is what we call regression. Now, meningitis and encephalitis are always mistaken on the exam. Okay, they mix them up. So meningitis is the brain and the spinal cord. The meninges of the meningitis goes all the way down the spinal cord and the brain. Now, encephalitis is only cephalic, head. It's only brain. Osteomyelitis is an infection of the bone. And osteo is always a bone. Sarcoma is a cancer, so it's a malignant bone cancer. Ray's syndrome is a acute non-inflammatory encephalopathy and hepatopathy. Hepatopathy. What it means is your liver and your brain get inflamed, and it's due to aspirin and having a metabolic syndrome that we don't know about. So Ray's syndrome is related to giving aspirin. So you would never give aspirin to a child unless it was ordered by the physician. And you're going to learn that next week, which aspirin is given for. Sepsis is a systemic response to either bacterial, a viral, a fungus infection, and it can result in shock and death. Sepsis. So Freud, Freud is all about anything sexual, mouth, anus, phallic, relationships, and then sexuality as adolescents. So just remember, oral is the beginning, everything is in the mouth, and pleasure and stress relieving is in the mouth. Anal is your toddlers, and that's when they potty train because we know stool comes before urine. Phallic is when they start being attracted, boys to moms and girls to dads, and they starting to learn that they have differences in their sexes. Latency It's a hard word to remember. It just means same-sex peers. That they girls with girls and boys and boys. And then the genital stage is that adolescent where they're starting to explore sex and other people and sex, and that is genital. So that's basically what I've said here. Piaget, all about thinking. So Freud is sex, Piaget is thinking. Remember, we're brought into this world and we don't know anything. And as we get older, we build upon what we've learned before. So in the beginning, it's just touching, feeling, moving, finding it. And pre-operational is now we're starting to do imagination. We're starting to know that if we throw things on the floor, mom's going to come. We're going to have a broom is now a horse. Your arms are the wings of a plane, that thing. Concrete operational. Concrete is something that's solid. You can see it, feel it, and touch it, which means you have already seen what you are trying to do. So you've seen it done before and you're replicating it. You don't think up of new things by yourself yet. But formal operations, they can figure anything out. They don't have to see it before. That is thinking, and that's Piaget. And that's all of that saying it a lot differently. Erickson, all about dealing with people. So initially, infants cry, mom comes, they get fed, they're happy, healthy, content infants. But there are times when mom, due to could be drug abuse, could be just physical violence in the house, could be homelessness, whatever, they don't get picked up right away and they just get mistrust. Then it goes to the toddlers, and toddlers explore the world. They're like a blender with a lid off. They're everywhere all the time, exploring. They're autonomous. Me, I want to do. The shame and doubt is when parents or somebody stops them from that exploring, or stops them from jumping off the couch to the other couch. They're trying to figure things out, and we stop them. That's the shame and doubt. 3 to 5, it's that preschooler, and that's all about trying to help and do things, but they can't do it all, and they do it wrong, and that's the guilt. Now, again, school age, probably one of the most tested areas is this one, industry versus inferiority. An industry is a factory, it's a building, it's something, again, you've seen, you touch, and you do it really well. So I am good at spelling, I'm good at running. That's my industry, that's my product I produce. The inferiority, what I can't, it's everything else that I can't do as well, and I want to do well. And then, of course, we get into the adolescent. Who am I? Who am I going to be? All about body image and all about so being confused what's going to happen to me as I grow up. Identity versus confusion. Now, Maslow, remember, Maslow goes on a hierarchy of needs. It starts on your physical, your eating, your drinking, your sleeping, and your toileting, right? And then it goes all the way up to what do I feel good about? So every child needs a little bit of all of that. They need safety, they need their love, and they need to feel good about themselves. Now, Kohlberg, just basically it is after infants and toddlers, because they don't really have morality yet. They're starting to learn no, and sometimes, the younger kids, oh, I know I shouldn't, but I'm going to do it anyway. But Kohlberg is more that preschooler, school age, and teenager. And it's all about trying at preschool, it's reward and punishment. So they understand. If I do good, I get a reward. If I do bad, I'm going to be a punishment, right? Now, school age, they want to do good and they want to please. That's them. Teenagers have to conform to the rules of society, stopping at the red light, stopping at the stop sign, or things that you have to do that's politically correct, in society, putting the trash in the garbage. All of those things are part of Kohlberg. Now, the hospitalized child. When does discharge planning begin? Well, as soon as I meet a child, I'm talking to them and I'm teaching the parents and the child as I'm talking to them from admission. It is really important that we try, especially younger kids, autistic kids, Down's kids, that we encourage the parents to stay at the bedside. It really does decrease the child's anxiety. We should always have, for these younger kids especially, incorporate home habits. And we need to include them in our everyday routine. Again, having something that they understand and know reduces the anxiety. Now, an altered state of consciousness, which means you're really not thinking correctly. Maybe you're asking questions over and over again. It's due usually to either you were hit on the head or it could be a lack of oxygen in the brain. And if it's that lack of oxygen for a brain, it's because your blood pressure is too low. Blood can't get to the brain with the oxygen, and then you get this altered state of consciousness. And that's what that is talking about. So we as nurses have goals when caring for hospitalized children. Some goals include, well, because it's family centered and you're only not just going to have a child, you're going to have a child and a parent. Just always reassure the parents. Tell them they're doing a good job. And then let them know exactly what is going on. With the children, you've got to maintain a sense of trust. If something is going to hurt, be honest. I'll give you medicine. I'll try to help you. I'll hold your hand, but it will hurt. Will it hurt for a long time, a little time, or just briefly? Let them know. Provide individual and flexible nursing care. Just remember, not every child with a broken bone is treated the same. Again, on the developmental level, what does a kid understand? What, to keep them calm, and it's hard to think that we should do the same thing all the time, but we need to be flexible. Another way to be flexible is, for instance, one of those children whose parents can't stay, separation anxiety, or a younger child. Put the same hospital staff with the child every day if at all possible. Always, yes, incorporate those home habits and transitional objects into the care, and maintain a home routine. I can't stress that enough. Bring their blankets. If they, play with their truck at this day, or they have an iPad at this time, whatever it is, keep the same if you can. Use soothing techniques to play and help the child work through threatening experiences. Play solves the world in a child's world, right? Play is everything. It's non-threatening. Always approve the appropriate play activities for children of different ages. Not playing checkers would not be good for a 2-year-old. It'd be good for a school age or an adolescent. But remember, choose the proper. When you have a child who has to come into the hospital for whatever reason, always try to help the child to restore normal growth and development stages after that surgery or procedures. Sometimes they're just about to walk and they get a broken leg. Well, now you've got to get them back to where they were. And remember, each age group is different, and identify whatever intervention for that group and incorporate it. Now, separation anxiety. There's 3 stages of separation anxiety. It starts about 6 months when they realize mom is gone. Sometimes later, but right at 10 months, mom and dad leave, and that child is not going to be happy. So parental involvement is the only way really to, solve, or the best intervention for separation anxiety. Stages are protest. Toddlers are going to be continuous. They're going to be crying. They are going to be, hitting the crib rails and until they fall asleep. So, especially toddlers, and they're looking and looking and looking for them. So, again, intervention, consistent caregivers. Don't let the mom say, okay, I'm going to go now. Oh, no, I'm going to go now. Okay, let me kiss them. Don't let me go now. No, no, short goodbyes and distraction. Give them a toy they like. Give them their teddy bear they like. Oh, that blankie that they like. And always reassure them that their mommy, their daddy will come back. Despair. Children are sitting there. They look sad, depressed. They withdraw. They don't play. Again, at this point, they're going to regress. And this time they're going to be sucking their thumb. Um, how do we get them out of it? Again, same caregivers, putting them with their familiar objects that they brought from home. And always make sure that when we're doing things with that child, that they're not tired, they're not hungry. Always be aware of those things. And then always talk about something that, maybe you'll surprise their mommy or daddy with when they come back. Maybe drawing them a picture. That's your distraction too. Denial and detachment. Children appear to deny their need for their parents after they've gone through all these stages. They're like, you weren't here. I'm not going to think about you. And now they're disinterested in all of those things. So they become more interested in you, their toys, and not their parents. So the intervention again, assist in building that relationship. Say, oh, look at mommy wore a pretty red shirt today. Isn't that your favorite color? Something. Remember pain scales? We have faces and we have FLAC. Remember, FLAC is from 0 to 3, but at age 3, it is faces. Also, FLAC is good for nonverbal children, your cerebral palsy that are unable to talk. So 0 to 3, it's FLAC and nonverbal. At 3, question says 3, it's FLAC. And FLAC 3 up is going to be that your faces. And actually at 8, it goes to numerics from 0 to 1, 0 to 10. What's the worst pain in the world? What's your number? That would be children at 8 can do that. So pain is whatever they say it is. And that's according to the American Academy of Pediatrics. And back in the early 2000s, they put it in, the Joint Commission put it in as the fifth vital sign so that we're always measuring it. So what's the best way to give pain management? And when you know the child's having pain, what they say is giving lower dose analgesics, but administered around the clock regularly. And don't just wait for it, okay? So give it around the clock. Acetaminophen works really well on children, mild, moderate pain. You have a child on opioids, they've had a fractured femur, they've had abdominal surgery. That's when they're going to get the opioids. That is sickle cell crisis, cancer, and those surgeries I said. Lidocaine is something we can put on topical, and we could put it on for suturing. We could put it on for staples. We can put it on for IV catheter placement. So it is used quite a bit in pediatrics. Conscious sedation, we've already been over it. They're asleep, but they have their airway. And remember, fluconazole is used to reverse your diazepams, your benzodiazepines, your Valium that's used for status epilepticus, right? So your diazepine, which is your Valium, that's the reversal if they've had too much. So your eyes usually are clear and white, but sometimes the mucus gets inflamed and it gets reddened. And this is called pink eye or conjunctivitis. It is a bacteria. And we know kids spread it on their hands from kid to kid to kid to kid to kid, from toy to toy to toy to toy. And they get it, and it's, their eye. So some of the terms, hyperopia is you can It's farsighted, which means, and I don't know why they do this, it's when you can't see near. And myopia is nearsighted, you can't see far. And why they did that, I think it's crazy. But you have to remember it. It's opposite of what the word you think it is. Amblyopia is when you have one eye that sort of the muscle goes in or out or up or down. And how do we treat it? We cover the good eye and let the muscle that's weak on the bad eye get better. And it usually strengthens it. Strabismus is when the eyes cross and they can't put these eyes both on the same uh, object at the same time. It's also could be more called cross-eyed is another word for it. Nystagmus is the jerkiness in the eyes. Simply, the eyes just jerk. Papilledema is when the optic nerve does get swollen and edema. Now, ears, types of hearing loss. Well, if you're born with it, it's congenital. Sensorineural hearing loss is when the hair cells along the cochlea and the acoustic nerve can be damaged. So that's more of the nerve. Conductive hearing loss is when the tympanic membrane, it prevents sound from going in. So it can't conduct inwards, okay? So some of the times, another sense that we think about is children who cannot hear. And we want to just yell at them and over pronunciate words. No, get on them face to face, eye level, of course. Talk to, get the eye contact going, and then short sentences. You don't have to over enunciate. Otitis externa. This is also called the swimmer's ear. It's only the external. So we treat that with antibiotic ear drops. That's it, not oral. Now, otitis media is a bacterial infection. Mucus from the throat goes up into the ears, pushes it out, and it's painful. So how do we treat it? Well, antibiotics, usually amoxicillin is your first line of drug. And remember, it hurts. So give that child some acetaminophen for that, mild to moderate pain. Okay, seizures. So what is seizures? I literally say there's something in the brain that gets zapped and it goes, and wherever it is in the brain, you're going to see an outward response. Okay. You might see stiffness, twitching, limpness, different behaviors, blank stares. There's all different types of seizures, but it's something's been zapped in the brain and goes, all right, and it affects that center. So the types. Grand mal is what we think of with a seizure. Arms, legs, general tonic, clonic, in and out. There are shallow, irregular breathing. Many times they lose stool or bowel or both. And then remember, it's that followed by confusion or a postictal period. And then they fall asleep because it is exhausting. It's a lot of exercise. Cheat mall is just simply sometimes a blank stare, or sometimes it's a little twitch, but it's called an absent seizure. So that, and usually it's just brief, and they don't go through all of that confusion and stuff. Jacksonian is a simple partial seizure, and only one area of the body could be an arm, a leg, or the face is going. Patient's awake, the child will be awake and aware. Myoclonic or atonic seizures are a jerking motions on awaking. So they wake up and they have these jerking motions, then they collapse, and it's like 10 to 60 seconds. Now, probably the most dangerous of all the seizures is status epilepticus. Status epilepticus, and status means it continues and you got to do something to stop it. And they say the definition is prolonged seizure for over 30 minutes. It's not responding to anything. And as what I said, postictal is that sleep after a seizure. So what can cause seizures? Well, a lot of everything. Infections. We know there's drug fevers. We know that there are fevers that happen. Rate of rise goes up really quick. Epilepsy, hypoglycemia. So those are all things. Now, you walk in a room, you find a child on the bed, and they're having a seizure. Clonic, grand mal. What are we going to do? Well, number one, if you have a child known seizures, you would always keep the side rails up. Okay. So in case of seizures, they can't roll out and fall on the floor. Anything that's around the bed that can harm them when they're banging and their arms and legs are going should all be padded to make sure. Also, anything in the bed that's sharp needs to be removed if it's having a seizure, that's for sure. And suction should be there. Now, you're not sticking anything in the mouth. The suction is to clean the suction. If they're turned on the left side, which is what we like to do, and they vomited there, this will suction it up so they don't inhale their own vomit, okay? Parents need to know that these children need to have some identification on, whether it's a bracelet, whether it's a necklace. Older kids will have it on their phone as a medical alert, of course, but younger kids, they don't have a phone yet. So something that dictates, so we know that what's happening to them. Medication, compliance on medications and visits is so important to these children. So really emphasize that to them. And one of the things we don't think about is, what if you are with a child, you don't swim, and the child's in the middle of the lake and they have a seizure? Now, that's not really good observation of a child swimming, right? So make sure that somebody is there that can be available, or you are able to go rescue them. They should never be alone, okay? So medication depends on the type of seizures, and our goal is to not have seizures and not have a lot of side effects, because many of those drugs do. So inflammation of the covering of the brain and spinal cord, called meningitis, right? It's not encephalitis, it's meningitis, because it's all the meninges. It's usually Haemophilus influenza. Now, if it's bacterial, this is where we are going to have all of, the meningitis symptoms of the headache, the neck stiffness, and they determine that it's bacterial. This child will be started on antibiotics. Viral meningitis does not get antibiotics. It is a virus, but we know bacterial will be, okay? Now, once you have given the antibiotic, those antimicrobials, for 24 hours, you can take them off of droplet isolation. It is actually in the air meningitis. Cough or not, it's in the air. That's meningitis. We need to, because it's something affecting the brain, that we do neurological checks. Anything, any changes, weakness, speech problems, confusion, behavior problems, tell the doctor, notify the doctor. Maintaining a good intake and output, because we know too much fluid can hurt the brain too. So intake, output, and watching vital signs. And because their brain is so irritable, maintain a nice, quiet, darkened environment and decreasing the stimuli. These children are at the end of the hall if they're admitted in the hospital. So types of fractures, sprains, and strains. So green stick is when an incomplete fracture on one side of the bone. So you have one is bent and one is fractured. Compound, it's the bone is broken and up sticking in the skin. And now we're worried about, it's been exposed to the air. We're worried about infection. Simple fracture is what mostly kids get. A little crack, whether it goes across the bone or partial bone. The skin's there, it's intact. We just put a cast on it and let it heal. Oblique is one of these complete break, but it's at an angle. It's not straight across, it's at an angle. Spiral. This one should put you on high alert. Spiral fractures are twisting, and you could see this is usually when you take your arm and you twist it like to pull them, and that's usually child abuse. So we have to be aware because we report child abuse. All nurses do. A sprain is when the ligament is torn or stretched away from the bone at the point of trauma, resulting in damage to blood vessels, muscles, and nerves. I've sprained my ankle so many times, it swells up, it becomes so purple, and I think they're more painful than a break. Strain is when you do something on the same peen repeatedly over and over and over again, and you get these little microscopic tears to the muscles and tendons. Could be in your shins, like shin splints we've heard of, very similar, less like a strain. And contusion, it's some sort of, damage to the skin, and then the bruising, the hemorrhage, the edema, the pain underneath. You bump into something, and it bruises. So those are pictures of the fractures for you to look at to know. Here's some bone issues. All right, scoliosis. This is something that we usually see more in the adolescent, like the 12-year-old. It's an S-shaped curvature of the spine, but what would make you alert? Well, you have one shoulder up, one shoulder down, and you'll see one arm looks longer than the other when they bend forward. That is your clue that it needs further investigation. Ewing's is a type of sarcoma, and it happens in long bones. Now, leg calf girth. It's the end of the bone and the development of the femur and the head of the femur, and it becomes without blood supply and it doesn't form correctly. So it's the disruption, it doesn't form right. And then you're going to have a problem with hip articulation. Juvenile idiopathic arthritis, JIA, is an autoimmune disease of childhood. It's about the joints, connective tissues, and viscera. Osteoarthritis affects 4 or fewer joints. There's some that one joint, some are multiple joints, and that's the difference. Osteosarcoma is a primary malignant tumor of the long bones. Now, Duchenne's muscular dystrophy is a muscular dystrophy that occurs in boys, actually ages about 3 to 7, and they are cognitively delayed and they're walking, but sort of waddling. And then all of a sudden they start falling down and they starting to get more muscle weakness. You're going to see their calf muscles are very, very big or hypertrophied. Okay. And we know Duchenne's is because they've gone up, they're walking, and now they're going back and they're not walking and falling down. And that would be a hint to Duchenne's. Torticollis is when your neck gets a crunch to it, right? And it's the sternocleidomastoid muscle gets pulled on one side. Buck's traction, it's a skin traction. There's no needles. It's used to hold a femur. So the femur is in the calf. Those muscles are strong and they pull those bones this way. And those little sharp edges attack the muscle and it hurts. So Buck's traction puts it straight so we can have it there on with pain be less, reduce it significantly until they can get to surgery. It needs to be straight, and we need to be checking the neurovascular signs. We always check for blood circulation. You don't see blood circulation, you see paleness in the feet, call the healthcare provider. So what does the traction do? It pulled that bone out. It, immobilized it. Now your muscle spasms are gone. You're not hitting nerves, and it's going to reduce deformities in the long run. As bones do reheal. This is the things you need to look for. It's the 5 Ps. Is it pain? Is it getting worse? It's the pulse. Is it what it used to be? What's the color? Is it white? Is it pink? Is it numb or does it feel okay? Is it movable? Is it not? Any of those that are a no, call the healthcare provider. But these should be a check on every single shift at least once. Now, there is other sorts of traction beside just the long leg pulling. The cervical traction is sometimes the neck. We need to pull the neck out. Crutchfield is when we put tongs and these go directly into the scalp and it pulls that, and it's for the cervical too. And a Steinman is what we used to use instead of Buck's traction to hold the femur straight. They put a pin through the leg, and with traction, it pulled that leg out. Same concept, pulling it from the leg with the weights, but it pulls it so it keeps it straight before surgery. Now, what is cerebral palsy? This is something it's a group of disorders that affect movement and muscle tone. It's damage that could be as it developed in mom, or sometimes there's hypoxic and anoxic episodes during the birthing process, and they had an oxygen deprivation, and their brains are affected, and they can get cerebral palsy depending on how long that was for. Sometimes we see it right away, and sometimes we don't. So it needs for us to be very aware. That's why we do all those developmental screenings. So in general, cerebral palsy is usually impaired movements. They don't move their arms the right way. Reflexes are different. There's floppy or they're rigid limbs and trunks. They don't sit right, so abnormal posture. They tend to move and they can't control them. Unsteady walking. Some of them, all of them, combination of them. Spastic CP is when you go really tight. I had a little boy who used to see me. He was a spastic CP. He was 7 years old, nonverbal. And he'd see me and he'd put his arms out and he would feel like his arms get so tight. That's that stiff, jerky movement that you see with spastic CP. Okay. Now, different from apoptosis. This is where they, their hand and they're trying to do something and their hand cooks up and they just can't get it there. It's involuntary. It's purposeless. It doesn't have any function that it does. And the kid can't eat the food because the hand goes into this, okay? And that's apoptosis. Now, opisthonotosis is this arching of the back and the muscles just contracted up. Now, child abuse. Remember that, spiral fracture? Well, that could be a trigger for child abuse, making you think. So what would be some things that would be identifiers? Well, the child's stress in parents. Now, these are parents we're talking about. Are they disabled? These children, are they temperamental? Are hyperactive kids that are on the go all the time are hard to work with? Sometimes foster children, stepchild, creates the stress on the parent. The social stresses, are they unemployed? Are they in poverty? Are they from a dysfunctional family? Parental stress, them themselves, were they abused as a child? Do they have a low self-esteem? Are they overworked, overwhelmed, undereducated, or are they having some sort of substance abuse, alcohol, drugs, whatever? And then triggers. Sometimes the trigger is they need to discipline, but they go a little bit too far. Family conflicts going on, there's substance abuse going on, and financial crises. And that's child abuse triggers. Now, child abuse could be many ways. It could be emotional, sexual, or physical. And these are all child abuse. So emotional is verbally, they're destroying their self-esteem. Emotional neglect, they're not held, they're not told, I love you, any of those things. Sexual abuse, you'll have all different things. I've seen fathers, uncles, cousins, brothers, next door neighbors, abuse in my career. Physical neglect is when they are not giving them what they need, whether it's food, shelter, clothing. And physical abuse is that's when you see those bruising, belt marks, burns, those sort of things. Remember, there's always dosage calculation. They'll still be the same. I know that you're going to listen to this. You're going to do a great job. There are dosage calculation forms. If you don't have them, let me know. But I will have this posted on my YouTube channel within the hour. You're always welcome to go there and to visit it. It's Professor Bogart.